First and foremost, I would like to say or express my gratitude for the opportunity to present at this meeting. Many thanks to Raul and all the organizers for giving me the chance to speak here. I have no disclosure. When we discuss fluorescence-guided surgery, we are referring to a technology that truly revolutionized the way we comprehend tissue and the information we acquire during surgical procedure. In this presentation, we will discuss various aspects of why to choose the true method when assessing a Sentinel lymph node. When we divide into the evaluation process, including what dosage to use, the essential feature of the camera that we use for these procedures. Additionally, we will cover the most crucial tips and tricks for successfully location a Sentinel lymph node using fluorescence. As we well know, the concept of Sentinel lymph node is not recently development. Its origin traces back to 1970 when Cabana first described the assessment of Sentinel lymph node to avoid complete lymph node dissection in certain tumors. In Argentina, he performed the first case in 1999 for a patient with melanoma. This technique has become the standard of care for stratification of certain types of cancer, such as breast cancer and also melanoma. The technique for Sentinel node detection has long relied on the blue dye on the use of technetium. The method comes with several advantages, such as high rate of node identification, but also with some disadvantages, how we will see soon, primarily related to implementation challenge. So each time we introduce a new technology, it is imperative that we clearly understand the reason why it would be important to replace the older method. When we focus on the use of blue dye as a contrast agent, the main disadvantages stem from its short half-life. Often, when it's administered, it can damage certain lymphatic vessels, which in turn can obscure the surgical field. It can also cause significant discomfort for the patient due to the permanent tattoo effect. Additionally, when we use as a sole method, it has a low detection rate, particularly in patients who have undergone previous surgery or those patients who are obese. When we discuss the use of technetium, one of the best methods for Sentinel node detection due to its high identification rate, patients are required to visit medical facility hours or even days before the procedure because for the marking process, which can cause considerable discomfort. The application of radioactive substance must be done while the patient is awake, making it an unpleasant experience. Furthermore, if the surgery is postponed or delayed for any reason, the identification rate of the Sentinel node significantly decreases due to the lost radioactivity over the time. Thus, the next concept we must grasp is not only when, but also how we should employ a new technology. As you can see, the application of ICG for Sentinel node identification has been well established for quite some time. The pioneering research paper originating from Asia in 2009 showcased that the use of ICG in producing an exceptionally clear visualization of lymphatic channels and Sentinel node. Initially, this technique was applied to detect Sentinel node in skin cancer. The camera, as you can see, were quite rudimentary, featuring small basic monitor and large bulky camera unit devoid of any advanced technology. Despite this, the lymph node identification rate was almost 100%. In 2013, a significant study was conducted in Italy by Veronese Group, which evaluated 134 patients with breast cancer. In this cohort, 246 Sentinel lymph nodes were identified. What makes this study noteworthy is the comparison between the use of a standard method, such as technetium administered the night before the surgical procedure, and the new method like ICG. The identification rate using technetium is almost 94%, for Sentinel node, whereas for ICG is almost 100%. This demonstrates for the first time that there are patients in whom technetium does not clearly identify a Sentinel node, whereas ICG, yes. A recent study, a named trial named Influence, was published in Annals of Surgery. Its primary objective was to evaluate the Sentinel node detection rate by comparing the use of fluorescence. In this trial, 102 consecutive patients were studied between August 2020 and June 21. The procedure involved initially identify the lymph node with ICG, followed by testing the Sentinel node with technetium. In this study, 133 Sentinel nodes were analyzed. The identification rate of the Sentinel node using fluorescence was 96.1%, whereas the identification rate with technetium is 86.4%. The use of fluorescence did not increase the operating time. As you can clearly see, there was a superiority in the case of fluorescence over the standard method. Our group recently published a meta-analysis in the journal Surgery comparing the identification rate of technetium blue dye and fluorescent method. In the analysis, we examined the detection rate per case of Sentinel node identification, the number of nodes identified, the sensitivity for detecting positive nodes per case, and the total quantity of nodes identified. A total of 39 studies were examined, 17 European, 21 from Asia, 1 from the States. Among these, there are 8 randomized studies, 27 prospective case control studies, and 4 retrospective studies. More than 4,200 Sentinel nodes were studied in which fluorescence were utilized. When we compare ICG with blue dye in 25 studies, there is a 97.4 detection rate with ICG compared to 76.4 with blue dye. The assessing the sensitivity for positive cases for ICG is 97.8 detection rate, while the blue dye is 80% rate. The sensitivity for detecting cancer in positive node is 95 in favor of ICG versus 80 for blue dye. When we compare ICG with technetium, we found in 23 studies that include 2,700 patients for ICG and almost the same for technetium. Upon analyzing the Sentinel node detection rate cases, we found that the identification rate is almost 98% for ICG and 97.1% with technetium. When we analyze the same rate per node, is 96.3% with ICG and 83.4% with technetium. When we compare the use of fluorescence against the two combined methods, we also found a superiority of fluorescence of the other methods. For instance, we analyzed 204 patients who were tested with all methods and found a lymph node identification rate of 98% in ICG compared with 96.1% with the double marker. Upon analyzing the identified rate of positive lymph node, we also describe a superiority in the use of ICG compared to technetium, 97.2 versus 95.6. This graph provides a unique visualization comparing the different methods for Sentinel node identification, both in terms of number of nodes detected and the Sentinel lymph node identification rate per patient. A consistent superiority of fluorescence is described as well as a lower rate of false negatives. And how about the cost of the method? In Argentina, we have analyzed the overall cost for performing standard techniques such as technetium with amount of $433 per patient. This is because technetium often needs to be administered by other services such as nuclear medicine and they require much interpretation by technicians. What happened with ICG It costs $7.5 per patient because the dose used is minimal and it's administered directly in the operating room. The dosage of dye to be used is an important factor to consider. Currently, we use 1 milliliter of ICG for each Sentinel node procedure involving fluorescence. This dosage is administered into 4 quadrants, whether it be around the tumor or the areola nipple complex. And what about the camera selection? Of course, we need a camera with a near-infrared sensor with a high resolution and also with a wide field of view. It had to be with a high image quality, small and portable, and of course with a good value. To properly perform lymph node procedures with efficiency, there are several details that you must consider. Can you run the video, please? Okay. The Sentinel node detection procedure using fluorescence began once the patient is anesthetized. We prepare the ICG by diluting 1 milliliter in 10 milliliters of saline solution. Then, we administer the solution sequentially, taking care to not touch the surrounding tissues to avoid false negative. We activate the camera and the lymphatic pathway beneath the skin. When the flow halts, we make an incision, as you can see there, and observe the Sentinel node in fluorescent light. After excising the node, we clearly the surgical field to assess if there is a second or third Sentinel node. This is a video in real time. You see the camera and what happened when you see the lymph channels and the stop, and this is the time when you have to do the incision and look the Sentinel node. This is with black and white light, and also you are dissecting in this moment the lymph node, as you can see with the overlay mode. You can see the difference between the lymph node and also the fat tissue around the lymph node. Another video in real time. Again, you can see perfect, which is the difference between the lymph node and the fat tissue around the lymph node. You can use, of course, a focus to dissect the lymph node. And this is a procedure that you can perform sometimes with local anesthesia, independent on the patient. So it's important to consider, after everything we see, that we don't need previous study required. It's not painful for the patient. We don't get radioactive dose. It's a short procedure, and of course, it's cost effective. And when we talk about safety, it have less toxicity than the other procedures. Finally, it's been approved by FDA. In conclusion, the detection in breast cancer patient with no clinical apparent metastasis, ICG is clearly and consistently superior to blue dye and either or not inferior or superior to technetium and both combined method. Thank you, Raúl again, and we hope